Hi, I'm David Liew from Melbourne, Australia, and I'm reporting here for Room Now, like all my four panelists here. And today, this is a Room Now daily recap from ACR Convergence 2023. Thank you for all your support and dialing in to all of our coverage that we've been putting out at this meeting. As always, ACR is a massive meeting. No one person can cover it all, but with the breadth of people that we do have, we hope we give you some of the best bits. So I'm going to, even though you probably know them all, I'm going to go around the virtual room and get everyone to introduce themselves, tell us where they're from, and then we'll get started. Aurelie.
Hi everyone. Hi David. I am Aurelie Najm. I'm from Glasgow. Super excited to be here with you guys.
Always excited to have you here. Antoni.
Hello, I'm Antoni Chan. I'm from Reading, United Kingdom. Glad to be here.
And very glad to have you. And Bella, last but not least.
Hi, I'm Bella Mehta. I'm from New York, but now right now in San Diego, reporting for the convention.
Yeah. And the weather's been lovely here, San Diego. Best weather in the US and the world, maybe. Who knows? And it's a really lovely conference center. Really lovely to have the poster floor back in person, beating heart of the conference. Maybe let's go through a few different abstracts. Let's get kicked off in some of that because there has been some really interesting stuff. Bella, why don't you tell us a little bit about what you found interesting today on the Tuesday, day 3 of the main program? Telling me a bit about being excited about osteoarthritis. Did I hear that right?
Yeah, yes. I think I scouted a bunch of osteoarthritis talks and abstracts today. One of the things that caught my eye was the Roy Altman RF Memorial Lecture. And again, this is sort of dedicated to one of the rheumatology giants who passed away, but also highlighting the work and where is osteoarthritis going. We're still using the guidelines that he created for defining knee osteoarthritis, the 1986, 1987 osteoarthritis criteria. I think there's a lot of like hopelessness sometimes in osteoarthritis, saying patients come in with pain and function disability, and what do we do with these patients? I think in terms of drugs, they talked about a lot of like trials with IL-1, the CANTOS trial, and the LODO-CO trial, which is the colchicine trial. And again, most of these trials were done in the population, sort of looking at cardiovascular risks. And now we, as rheumatologists, are doing post-hoc analysis, looking if this medication, either IL-1 agents or colchicine, works in a way. I think the medications don't work that well. What Tuhina Niyogi highlighted in the lecture while she was doing this was that we need longer trial durations. We need to sort of work on this and like give whatever treatment we want slightly early on, because once the joint is totally damaged, it's very difficult to show efficacy with any of the medications. With that, I think that we still need to highlight, and the hopefulness in osteoarthritis is things like weight loss, exercise. They do work. They work brilliantly. There was a lot of data shown in this meeting that it works. And we need to encourage patients to do so. And even simple things, like it doesn't need to be fancy modalities, just simple walking, quad strengthening, healthy diet, weight loss, those sort of things.
Well, I remember being told as a trainee by Flavio Cicottini that whoever invents a therapy for osteoarthritis will get their own private jet, and I suspect that's still true. Really interesting to see these study design issues, and COVID's obviously truncated a few of the studies which we'd like to have seen longer term data. I think we have the same issue in a number of diseases like scleroderma and Sjogren's, where we want to try and get these patients earlier than we do. We end up seeing patients with a bit of damage. So, Bella, let me ask you first, what do you think in amongst that? Where are the promising therapies? Who are the most promising therapies in amongst that? And are there efforts that are being put in place to try and get these patients earlier? Are we phenotyping these patients, for example?
Yeah, so I think I think Orsi is trying to define early osteoarthritis. Like, I think that's step one. Like, I think they've put out the first few papers sort of scouting and defining that. Only once you define them can you enroll them. So there's a lot more work that needs to be done. In terms of therapeutics, like, Wnt pathways, there's like a bunch of new therapeutics, but they are not in, as I say, like in game time right now. They're still sort of in early phases, and we have to see. But there's some of them are promising. We will need to see the data coming up in the upcoming ACRs.
I mean, you mentioned a little bit about these ideas of trying to modulate IL-1 and I guess colchicines along those lines. Have we given up on that, or is that something that we're still trying to pursue? I mean, there are obviously therapies in that space.
I think that OA is such a heterogeneous disease that I don't think that one agent like a TNF for RA is ever going to work for OA, and that's what all of these trials are telling us. I don't think that IL-1 is completely given up, but I think going upstream, phenotyping patients and finding subclasses is what is needed so that we can treat these patients.
Yeah, absolutely. I mean, obviously, beyond just the involved joint, and knee osteoarthritis is not the same as hip, which is not the same as hand, which is not the same as, and even hand, we're starting to see different phenotypes, but clearly trying to identify inflammatory phenotypes within those is another challenge. I mean, Antoni, Aurelie, what do you think are going to be have you got any thoughts on what the best bets are? How am I going to get my private jet? Probably not rheumatology, let's be real.
I think the issue here is about the assessment. I mean, obviously, the treatment response will be very much dependent on structural changes, but equally on pain as well. And I think we had in the past looked at targets such as nerve growth factor, where it might affect the pain levels. I think it's a bit more complex osteoarthritis than being just pure inflammatory target, for example. There will be structural and neural pathways that we probably haven't fully dissected yet. So to get my private jet, I think there'll be a couple more layers to get through before I get to fly it.
Yes, and tanezumab, friends, the anti-nerve growth factor, friends probably thought they were going to get their private jet. Doesn't look like that's the case anymore. So I guess there are lots of traps along the way. I mean, do you think it's a kind of thing where we might go back and look at some of these, Antoni? Do you think we might look at some of these therapies that we've kind of discarded and go back again? I guess that's what methotrexate, the redo there has been about, trying to select the patients with hand osteoarthritis with synovitis on MRI. Are there other therapies we might go back and have a look at?
I certainly think so. I think, as you clearly pointed out, David, this is quite heterogeneous, both in terms of regional differences, say hand versus hip, but also within that different subsets or subtypes. And also we got the phase of early versus late. So I think we'll probably have to dissect it using some molecular or genetic tool in order to analyze this a bit more.
Yeah, well, now we're getting cracking in those. I think the technology is clearly becoming more accessible, so that's promising. Aurelie, any other thoughts on that? If you're going to bet on one of those therapies?
Yeah, I mean, you know what I would really love? And it's not even a therapy. It's, I would really love for us to give the same amount of effort that we give in trying to characterize RA. We've been looking in the tissue. We've been doing single cell analysis. We've been doing spatial transcriptomics. We do that in many different conditions. I haven't seen that in OA yet. And I'm pretty sure there's a lot to discover with these approaches as well. And that would help us dig further into, the phenotypes and then stratify people. And once we do that, I'm pretty sure we can go back and see what drugs work in which patient subgroups.
I so agree. I think, even though as rheumatologists, I feel like majority of our patients, whether we want it or not, come in with osteoarthritis pain, and we've sort of ignored it for a very long time. I think the NIH, we're part of the Rejoin Consortium. They're trying to get these sort of detailed phenotyping and genotyping done for osteoarthritis. So, but it's still in the nascent phases, not as much as RA. So we're getting there.
I mean, Aurelie, you're a big synovial tissue transcriptomics person, so you're putting your hand up. You want to be contacted by some of the osteoarthritis people? Yes, that's a hand
Get in
up.
touch.
Well, you've heard it there, so you know how to get on to her. So, Aurelie, why don't we talk about something beyond osteoarthritis? Let's move along. I guess another back to the future type thing, tapering. Shall we talk about DMARD tapering?
Yes, absolutely. I think there were like two really interesting results. One was abstract 2543, and that was the DMARD, kind of the conventional synthetic DMARD branch of the Arctic Rewind study. So just a reminder for those who are not familiar with it, there had been data published already after 1 year in the JAMA a couple of years ago. So it's a randomized control trial where they take patients that have been in remission, drug-induced remission for over a year with rheumatoid arthritis, and they just randomize them with either they keep the same dose of their conventional synthetic DMARDs, or they go half dose, or they go half dose for a year and then withdraw. And then the follow-up was at 3 years. And they did the same thing with TNF, and that was another abstract. But I think overall, what's really kind of cool with that is there's a lot to discuss, right? There was 150 patients, 140 roughly completed the study. And so the first thing that's really important is that 80% of those who remained on a stable dose were still in remission after 3 years and didn't experience any flares. 57% of those that had the half dose were still in remission. And then 38% of those who withdrew were is still in remission. And so you can see it half full of half empty, right? You can say, oh my God, it's terrible. It's only, a very small amount of people. Or you can say, wow, 40% were in drug-free remission. And who are these people and what are their characteristics? Because we don't know that yet. But as per the trial, the non-inferiority criteria was not met. The good thing, though, about those who did flare is that the recovery rate was 75%. But that also poses a question, which is, who is this quarter of people who actually, stop the drug and do not recover? And it's particularly important for conventional synthetic DMARDs. And then one of the important results as well, to my opinion, was the radiographic progression. So 1% of those that were on a stable dose did progress over 3 years, which is very low. And then 19% of those that had the half dose progressed. So it's quite, a lot. But then those who did withdraw was only 11%. And I think the reason for that, it was because these patients' exposure to biologic was much higher, as opposed to the half dose guys who remained on the same kind of drug. And so those who withdrew were exposed to biologics in 18%, as opposed to 9% in the stable dose. And so I think and in terms of safety, there was no major difference. And so what this is telling us is that, yes, there is a group of people you can, safely withdraw, but you don't know who they are. And there's a group of people you certainly don't want to withdraw, because if you do, they're gonna flare and they're not gonna recover when you start them again on treatment. And this was fairly similar for the TNF. The TNF was the latest abstract, number 7. And so same thing with TNF inhibitors, either they withdraw after 4 months of tapering or they just remain. And then the numbers for remission were I think we were roughly in the 80% range again versus 25%. And so in that circumstance, and the recovery was okay as well, but there's a big difference there. So yeah, I think that for me was quite, important in terms of, do I really want to offer tapering to my patients? Considering I don't know, who's gonna do what is going to be the trajectory at the individual level. So we need biomarkers. Tissue is the answer. I'll tell you.
Tissue is the answer. That's the second time you said that tonight already. So I think that's the second bit's a really good reminder that we never want to get complacent, that where we've come from in rheumatoid arthritis, and not that long ago, we used to have clinics full of patients with destroyed joints everywhere. And I think that we don't want to forget about the radiographic damage that we potentially risk, that DMARDs protect us against by definition. So look, I think that that's really fascinating that there's such a high rate of radiographic progression in that half dose. And that's not kind of thing you also don't see from the shorter follow-up from tapering studies. Did that surprise you? And I guess how significant is this radiographic progression, Aurelie? I mean, are we talking about, one sharp band higher score, delta, or are we talking big differences?
Yeah, no, it was three. It's superior or equal to 3. So again, yeah, it's but I'm just, because there is obviously the observer, and an intrapersonal, but I think what would be really good would be to see, if that was increasing over the 3 years.
Yes.
And if what the data was, because those who start progressing and then it's 3 and then it's 6 and then it's 9, these guys are definitely progressing, and we don't know what the percentage of these people was, so it's hard to answer, but yeah.
I guess it's interesting because we've got a lot of inter-individual pharmacokinetic variability with TNF inhibitors as well. We've seen the therapeutic drug monitoring studies where people scatter out. So you'd imagine that weaning, you'd really kind of bring people back down the curve and accentuate some of those differences. So do we think that maybe there's probably better ways of trying to deal with that side of things as well, Aurelie? I mean, if we're going to reduce, should we be trying to do it on drug levels or something like that?
Yeah, I mean, are you talking about finding this group of people that actually is not going to flare? Is that what we're talking about?
Well, I mean, I think there are a lot of patients would like to reduce their doses, even when we try and hide that idea from them. And maybe we would like to reduce down exposure. Maybe people would like just to take fewer meds if they could get away with it. So, I don't know if Antoni, Bella, you've got thoughts on this, and I guess this idea as well, like Aurelie brings up, of how are we going to start picking the winners here in terms of tapering?
I think it boils down to risk prediction, right? Or prediction probabilities and subtyping. Like, this is again going to the same theme, I guess, saying if you could know that these are the group of patients which will do okay, you would stop, you will start withdrawing therapy. Nobody wants to keep patients on therapy when they don't need it. But I'm curious, like when you say tissue is the key, but even if we go on biopsying these patients today, we don't have the answer. I mean, we just know that they are not flaring right now. I don't know what the future holds, does it?
Yeah, I mean, there's been a study that's been published. It was in Nature Medicine paper that was, looking at what differentiates those guys that are going to flare and those that are not. And so there was this specific, I mean, you would have to do single cell at the moment, and you can't do that at the mass level, right? Obviously, but if you were able to find, so there was this cluster of cells, right, of macrophages, tissue-resistant macrophages, that they were present in those people that were flaring, and they were not in those that weren't. So there is this cell kind of subset that's there and that is driving this. So if you find a way to correlate that in some kind of blood, biomarker, then there you go. We haven't done that, but
then you fly a jet.
Well,
jet.
We'll never tell Aurelie that all synovitis is the same. Don't ever tell her. Don't ever suggest that to her. Antoni, you got any thoughts on how we're going to pick how we might pick the winners if we are going to have to taper? And I know that Jack, if Jack was here, he'd tell us that this is all ridiculous and we shouldn't be bothering with tapering studies. But let's say we are tapering. How are we going to pick the winners?
Yeah, I think all the points that were raised, if we could have a better predictive tool as to who is suitable and who's not. But if you look at this study, the Arctic Rewind, we are faced with two groups. One group who carried on with TNF, the stable group, they did very well. And then you got a group who, when you tapered and stopped, they didn't do so well. So my reading of this is that you probably should do something in between. Rather than stop, you should dose optimize them to the dose where it's best for them. And so I think it was quite a quick drop here. I think they had 4 months of half dose in the biologic arm and then stop.
Yeah.
Now that to me is quite a drastic drop. Maybe they wanted to prove the point. But I would say, and there are many other studies, and the studies will be very much, the results on the studies will be very much depending on how you taper. So we know that from previous studies where they did, say, 66, 33%, or 60, 50, 33, and then kind of stopped there when they felt that they were, the disease was going up a bit, but not enough to be a flare, and then left it at that. Probably something in between the two would be my way of seeing this, until such time when we got very good predictive tools, be it biomarkers or synovial tissue. We probably shouldn't risk our patients having a flare.
Absolutely. I mean, we've got so many levers now that we don't have to blindly try and reduce down these meds. But I suspect that when I go back to clinic next week, that I'll have patients who have still reduced down their meds without even telling me. So such is the way of life. We will keep on trying to do something better. Speaking of which, I think, Antoni, you want to talk about a JAK1 inhibitor. Why do we need another JAK1 inhibitor? Why do we need another one?
So, when the JAKs came out, we called them just another kinase. So here we are, just another me too. Another one today. An L late breaking abstract L09. And the compound is called LNK01001. I'm sure I'll get a name very soon. A selective JAK1 inhibitor. So we know we already have selective JAK1. So why is this so important? Why am I highlighting here? It's because firstly the rapid onset of this. Within 1 week, 18% of people in the study had ACR 20 and 23% had ACR 50. And then at 12 weeks, that went up to 60%. For ACR 20, but remarkably at 24 weeks, 91% had ACR 20. Obviously, the placebo arm finished at 12, so there'll be a crossover. But even then, that is quite a significant improvement, which is great news for us. But then it calls into question, are all these JAKs the same? Do they operate in different concentrations? If you go from 12 to 24, do you inhibit another JAK? Maybe you got a bit of JAK2. We don't know the exact pharmacokinetics of this, but the dosing at 24 got you a very high ACR 70, 23%, it was 42% for 50 and 23% for 70 within 12 weeks. So, I think it's something that we should just keep an eye. It's early days, it's only 24 weeks. It'll be interesting to see the longer term data.
So, I mean, if we're talking 60, 40, 20, and we used to live by the 60, 40, 20 rule, 90 is a lot higher than 60. You should never compare. These are not comparative effectiveness studies. This is an early phase study. So do you think, Antoni, that this is plausible? Do you think that this makes sense if we've just got two things which are nominally acting on the same pathway? Maybe we're not, maybe these aren't quite as exact as we pretend they are, but does it make sense? Oh, and do you believe it? And I guess the other question that comes about, some people ask the question, what's the clinical trials infrastructure in China? Are we seeing similar types of things? There have been some questions about that this week. What do you think about that all?
I think, like I say, I think early days, and I think we want to see certainly 52-week data, which I hope they will present probably at the next meeting. But there seems to be a concentration gradient here. So I wonder how selective it is for JAK1 as you go up from 12 to 24 milligrams. We know that from other studies, as the concentration goes up, it becomes less selective in some of the JAKs. Whether we are seeing such an effect, I think time will tell.
I mean, there was some data not represented, but there was further data presented for TLL018 earlier in the meeting. I think we've already we've covered a bit of that on Room now. That's the JAK1 TYK2 dual inhibitor, also from China, that went in a head-to-head in a phase 2A against tofacitinib and absolutely smashed tofacitinib. And Roy Fleischman said that this is a spectacular compound, unbelievably spectacular. And so I think, and the speaker did mention that, in fact, they're pursuing a Chinese registration first and not going to go with multinational multinational trials that may initially lead to registration in the US. Do we think that we can keep on doing, maybe I can ask Aurelie and Bella, do you think we can keep on doing better with JAK inhibitors? Or have we reached the ceiling of where we're going? I mean, that sounds a bit existential, but I guess the question is, should we be looking to try and continue to improve our JAK inhibitor armamentarium, knowing that we've possibly had our enthusiasm dampened a little bit by oral surveillance?
It's a tricky one, isn't it?
Yeah. I don't ask easy questions. Yeah.
Because, it's not only the efficacy, it's also, the tolerance and the safety. And, there's been a lot of discussions about, how selectivity affects tolerance. And, we also know that selectivity is quite relative if you think of it. It's an in vitro thing, not necessarily an in vivo thing, right? And so I don't know. I think this compound, if it's true, then my answer would be yes, let's go ahead. Let's do dual inhibition. Let's, but I would like to see that replicated somewhere else. Or, I would like to, I don't know. It just sounds too good to be true.
I guess I'm a skeptic too. I feel like there'll be some horrible side effect which we've not seen in this data. And I don't know, it just makes me nervous.
Oh, you're such a nihilist, Bella. I have some optimism in life. No, I mean, I think that clearly we want to look for good therapies wherever they come from, and that the infrastructure in China, the clinical trials infrastructure in China has improved a lot in recent years. But understandably, we outside of China want to have a good, if there's something good there, we want to be able to test it and have a good use of it in our clinic. We want to have it registered for us. So I think that's part of where that comes from. I guess what do we think about in terms of some of these dual inhibition approaches that we're starting to see? I guess TYK2 inhibitors are quite considered to be quite safe generally. So yeah, what do we think about adding that to JAK inhibition as well? Any takers?
Yeah, I think that's probably the kind of question, isn't it? As we maximize on the JAKs, whether we could go further with TYK inhibition as well. So far, from what I can see, it seems to be fairly safe. But like I say, many of these things we need to take it out for longer to see what the impact is.
Absolutely. All right. Well, the one thing I did want to talk about from my expeditions today was another one on the late breaking, which was on dazodalibep, the CD. Nearly didn't get that. The CD4 ligand inhibitor. We for Sjogren's disease, we saw dual abstracts for that at EULAR this year. We saw, in fact, on the late breaking poster floor, further 6 months from the study, which looked not at the Sjogren's disease with all the terrible organ manifestations, but more, well, not from that point of view, but from the point of view of the symptoms that bother patients. And I think that we all feel very vulnerable with how well we can treat sicker symptoms. Really clearly does impact patients' quality of life substantially. And we seem to have nothing that can actually, we seem to struggle to find things that can modify that the immune processes that sit behind that. So I think that's where the need comes from. We saw at EULAR these data looking at the CD4 ligand inhibitor with some really lovely results over the first 6 months. What they did in the next 6 months, they did a crossover trial. So the patients who'd been on active drug for the first 6 months went on to placebo, and the patients who on placebo went on to active drug. And what we saw really interestingly were that the patients who had been on active drug and crossed over to placebo had a sustained response as far as their ESPRI is concerned. So the patient reported component in terms of the symptoms, which I think is really enormously pleasing, this idea that maybe we would have sustained benefit. And then we saw the patients who crossed over to active drug catch up as well. So, I mean, this is a phase 2 still. We'd love to see the phase 3. We've got excited previously by phase 2s in Sjogren's, probably too excited because we're desperate, and, desperate people get excited over some things. We'd love to see phase 3. I think it's in the pipeline. Any other thoughts from the group on that CD4 ligand, on dazodalibep?
Yeah, I think with these studies, the patient selection is quite important. Certainly for conditions like Sjogren's, you probably have to get people with lots of antibodies and lots of immunoglobulins, and positive for lots of things, for this probably to be more effective or to show the benefit than to have maybe antibody negative type patients. That would be my prediction at this stage.
Oh, we're in a personalized therapeutics mode tonight, aren't we? It's Aurelie's influence. He's sitting there just looking at us. Yeah, I think that's certainly, I think, and there's been a lot of work done in Sjogren's in recent times to try and stratify. So I think that's probably key. I actually I'll make a quick call out on another stratification bit of data I saw today, which was in the immune-related adverse events from Laura Capelli from Johns Hopkins. Phenotyping in her cohort inflammatory arthritis and finding using latent class analysis. Putting an element of taking away that element of subjectivity and finding two different phenotypes, one of which was more severe and may well be useful in terms of targeting therapies when we're trying to balance out, trying to control an immune-related adverse event from checkpoint inhibitor immunotherapy versus not overwhelm the checkpoint inhibitor immunotherapy. So lovely work there as well. Let's we're getting up to the half hour, so let's just I think it's always nice to reflect. This is another conference where we've had the poster hall back again, like we said, and we've had a few other changes. I think we're kind of getting to the expectation that this should be similar to how things were in 2019, but with all the added benefits of a virtual component, or some virtual component as well. Let's go around the room and say what we really liked about this year's meeting, and then what perhaps we hope might change for next year, and hope and pray that the ACR listens to us. So I might start with you, Bella. What did you like this year about the conference itself? And then
I think San Diego is great. I think that's
like
the top thing. The conference center was great. The posters definitely were the highlight. And I think for the next year though, I wish there's much more sort of the app and the where to go when. The app and the sort of the website work a little better. And if there's food there, I would love, with the registration, we need to get at least some food.
Well, and Yola often they have, quite, they have quite good food. I mean, there's, paella, and we had all sorts of beautiful pasta in Milan, lots of fruit out. Yeah, I'd love to see that as well. Antoni, tell me, what do you like about this? What did you like about this year, and what would you change?
It's great to have the physical posters back. I think the networking and the interaction at the poster boards were amazing, and you will never get that with virtual posters. People won't often have a chance to look at them, but this was just strolling down, and there was enough time as well. So I really like that they made some time for us to, really appreciate the people's hard work, because a lot of these, especially the kind of basic science people who spend hours and hours, producing that poster, deserve some recognition for people to come and talk to them and ask them about their research. I really like that. I think in previous years, the apps were better. I'm not quite sure how we reverted back to the app being less user-friendly this year, because in previous years, they were a lot better. For example, it's only today I found out how to look at my actual schedule, which is scroll as far as possible to the right. Things like that, minor things, nothing major, just little things. And yeah, I think it'll be good for them to have some packed lunch so that you can take it away and go to whichever session you like, and make that part of the registration rather than having to pay, when you go for your lunch. But otherwise, San Diego is great, and it's great to be back.
I mean, I love that we are so that we love the overall meeting so much that we get to we get concerned about these things. But I think it's possible the ACR have had one or two bits of feedback about the app that people struggle to open. So I'm sure they're going to hear that loud and clear, and that next year it will be better. Aurelie, give you the final word. What did you love about this? I mean, you've obviously got the beautiful sunset behind you. Yeah, definitely. I mean, it does look like that outside, though, I have to say. It's a bit darker now, but it did look like that, didn't it?
Yeah, I took it yesterday. And I was about to say, look at this. What is not to like about this view, right? Yeah, no, I've really enjoyed it. I think from my perspective, the amount of science that was presented, it was just massive. There were so many abstract sessions running in parallel. That was just impressive. And the amount of posters. It was just a lot, and in a good way. You had no time to be bored at all. And apparently they did only accept 50% of the thing presented as posters, which means that there were a lot of submissions as well. And I think it's just, I think the scientific committee did a great job. I'm quite happy. The app, didn't work. They still didn't manage to look at my schedule, but I went back to the paper version and that was fine.
Absolutely. I mean, we find a way, and all the good people on the AMPC, on the program committee, really work hard all year to bring us an excellent meeting, and you can really choose your own adventure. There is so much great content. I know I say that every time, and it sounds cliche, but it really is. This is the reason why people come from around the world to this. Well, so thank you so much, the three of you, for joining me today. Thank you, Bella, Antoni, and Aurelie. As always, I hope we'll see you all either in Vienna for ULA 2024 or Washington, D.C. For a week and a bit after the election in next year as well, at ACR, bigger and better with more and more content. So thank you so much. Have a good evening and enjoy the last half day of the conference.
Thank you.
Thank you, everyone.